So I'm Dr. Larry Bucshon. I was a cardiovascular and thoracic surgeon for 15 years in Indiana. And then I got this crazy idea to run for public office. And I was fortunate enough to get elected to Congress from Indiana's 8th district. And I served in Congress for 7 terms, 14 years, spent a lot of my time working on healthcare issues, as you might imagine, on the Energy and Commerce Committee, and worked on all kinds of things, including things that impact your community. And so I was really pleased to get the invite to come and moderate this panel. And I think what I'll do is I'll just have everyone introduce themselves, and then we'll get started with some questions. So,
hey, good afternoon, everyone. My name is Chris Porter. I'm Vice President of Government Affairs and Policy for Travere Therapeutics. I'm also a rare disease patient myself. Travere is based in San Diego, and we are exclusively focused on identifying, developing, and delivering rare disease treatments.
Thank you. Hi, everyone. I'm Maggie Kang. I'm a physician, a radiologist, and a mother caregiver to my daughter, Nell, who was diagnosed with a rare disease called neuromyelitis optica spectrum disorder, better known as NMOSD. It's a rare neuroinflammatory disease that disproportionately affects women and people of Asian and African descent. I'm also a rare disease advocate for the Sumaira Foundation, and I am also a resilience and healthcare coach, helping families and patients navigate the complexities of healthcare and developing a resilient mindset to live with rare disease.
Hi, I'm Tori Jem. I'm the Director of Policy and Regulatory Affairs at the National Organization for Rare Disorders. We're a patient group. We're a membership organization. We have over 355 patient organizations who are members of NORD. We have an over 40-year history that really originated out of the advocates who helped pass the Orphan Drug Act. And so advocacy remains at the sort of heart of our organization. Happy to share more later.
Hi, I'm Annie Kennedy. I'm with the Everlife Foundation, as is Abby Hauser back there. And we're an evidence-based policy organization that focuses on policy in 3 main areas, which we'll talk about today. Diagnostics and newborn screening, the intersection of infrastructure for therapeutic development, and then access to care and approved therapies. So it's a pleasure to be here.
Well, we have a great panel. I forgot to mention, now I'm a senior policy advisor at Holland and Knight, one of the sponsors of the event, and I'm happy to be here. I guess we jump right in. I'll make a few opening comments about, there's not really much going on in Congress, is there? I didn't think so. or the administration. And I think, let me just say this, we're watching very closely the things that could impact your community, budgetary cuts, both in the research area, consolidation of or decreasing the size of the Medicaid program nationally, which could impact the rare disease community. And, of course, administrative changes, consolidating different agencies within HHS and how that might impact you all. I'll give quickly from a congressional perspective. I think it's going to be very difficult to make dramatic funding changes and programmatic changes in the Medicare space, for example, and you're seeing that. So I'm cautiously optimistic that a lot of what's happening as it relates to federal health care programs won't be dramatically altered. There will be some, I think, around the edge changes. That's the way I kind of see it. And the other thing is I think you're going to see congressional support for research funding when you get through the appropriations process, which actually funds agencies like the NIH and the National Cancer Institute and others. There has been broad bipartisan support, including from people like me, for many, many years for research. I think the struggle is what the research dollars that are allocated go to, and I understand I know there's philosophical differences on that, and we'll have to work through that. So with that, let's just jump right in. Why don't you all just describe what are your biggest concerns about what's happening either in the Congress or the administration and how that might impact the rare diseases community? We'll get everyone's perspective and then we'll go from there.
It's like a hot potato, like who wants to go first? I think I've had the privilege of getting to be here all day. So I just want to commend all the panelists who've gone before, because those have been really phenomenal panels. As I've been sitting here listening to everybody speak today, I started my career in this space working in our clinic spaces in the neuromuscular space and working directly with families who were starting their journeys. So on diagnostic odysseys, and then being identified with their diagnoses, and then having the privilege to do direct care and direct service for families when I first started. And how I got to where I am now is that there would be real barriers to that care, to that access, to that benefit eligibility that were insurmountable. As hard as we worked to try and connect people, there just were sometimes no pathway forward for some families. And I worked at Hopkins and Children's National here in DC, and then covered some clinics in West Virginia. And that really thrust me into wanting to help fix it, wanting to help change it, wanting to help pass laws and policies that would help solve for some of those barriers. And so I was sitting here thinking that policy, over the 30 years that I've worked in this space, I've seen policy can really help solve problems and protect people and expand resources. But I think what we are seeing and experiencing is that policy sometimes can do the opposite as well. And as patient advocacy organizations, we are seeing resources change. We are seeing across HHS resources change. We had a conversation just earlier around even some of our PAGs have lost some funding and resources recently. And then the individual communities that we serve and work with, their protections and resources are changing. And that's a real reality for us to be thinking about right now as we think about how we even prioritize what we work on from a policy and a legislative standpoint, because it can feel like whack-a-mole. There's so much chaos even in the space as to what we're watching for, how many executive orders are being issued, how we even think about how much of a concern is that executive order, how many layers will there be before that becomes a reality. I'm sure we're going to be talking about therapeutic development incentives, Medicaid, newborn screening. I mean, there are so many things that we'll be able to cover here. But I think the most important thing that I think about is the individual families that we serve and how those families navigate their individual journeys, and how we as service providers, which is the beginning and the end of the day is what we're here to do, ensure that the policy we're working on and we prioritize is bettering that journey and is ensuring that we are protecting people with policy and legislation. So I guess that's how I would frame what gets me out of bed every morning, what I think about at night, is are we putting our time into that type of policy work?
I'm happy to go next.
Anyone.
Annie's framed a lot of important pieces. I think just over recognizing that over the last few decades, we've had enormous progress in the rare disease space in a lot of ways, but still a lot of work to be done. And so I certainly think about, in particular in this moment, thinking about what is worth preserving, what has actually moved the needle for those individual families. How do we identify those things, and how do we continue to champion them in more of a prioritized way than maybe we have in recent years, where we focus on what more can we do, what more to make this better, to keep that progress going. This is a moment where we have to stop and also refocus attention on what have we done that has been successful, and how do we make sure that that work is preserved and not lost in this time, while also navigating the both challenges and opportunities that change brings to make things work better for our communities.
Yes, and just sort of then sharing my, caregiver and physician perspective as possible area to focus. I was thinking, I've actually thought about this quite a bit for years, but I feel like it's more important now. And I think that one thing to consider is this trying to form partnerships and education with the frontline healthcare workers. And I will tell you that specifically, I'm thinking a lot about the emergency room doctors. And that is because oftentimes it's the first place where our rare disease patients seek help for a critical episode. And unfortunately, they don't often experience positive experiences with their interactions. And I do think that this is even more important for the marginalized communities. So specifically, from our disease perspective, I've heard countless stories that I want to share with you that NMOSD disproportionately affects women and people of color. And a lot of these women have presented to the ER with vision loss and paralysis, which are the aspects of our disease, and they are dismissed. And every time I hear this story, I'm always so shocked. Like, how could that be? Like, are they being accused of having some kind of mental defect or being dramatic or something to that effect? But these are urgent symptoms that need to be addressed, and they haven't been. And that has led to some very devastating consequences for so many of our patients. So I wonder if the partnership would be really helpful. And I want to also share another story during my residency that really shed light on the value of that. I was a rotating intern or resident, I think, in the ER at the time. And I remember there was a South Asian patient that showed up with dizziness and nausea. And I was thinking, okay, I don't really know what's going on with this case. So I presented to my attending. And I remember he said, we have to consider a heart attack. And I was thinking, really? And he said, yes. And it was because he had read a study that highlighted the fact that South Asian women present atypically. And so that one information just altered how we managed that patient. And in fact, that was exactly what she had. So I do feel like there's so much that we can bring similarly into that. Like, I'll speak again about our NMOSD just because that's the disease I am most familiar with. But I think this could be applied to all rare diseases, is when you have that education and doctors are made aware of the disparities and the clinical urgencies, it does change their practice. And I have tremendous faith in that. And so I would really like to maybe discuss that possibility and see how we can maybe create policy changes to support that effort.
Thank you, Maggie. Wow, it's tough to follow these three amazing advocates. I would think Doctor would agree we are the two thorns by two roses situation going on here. But
we should have split up.
I gotta say, but I think we are. There's no doubt, right? We're in a period of disruption right now, and it's tough to see the opportunity. And something Maggie said really resonated with me, that when you're in our business, which is solely focused on making new treatments for people living with rare disease, people think rare diseases happen by random. But in fact, there's clear patterns that tie the disease states to genetics and to geography and to ancestry and sex. And we wouldn't be doing our job if we didn't take that into account. And really the opportunity that we have, is to do that early targeted education, right? For both patients and providers that leads to that screening. And then we also have to be, worried about all those people, if you're lucky enough to get diagnosed with a rare disease, that you can actually get that care and treatment. And we find ourselves in a way, for those of us who are involved in developing drugs, that when our patients, because you come so close to patients in the development process when you're in rare disease, it's one of the most rewarding things about being it, when there's barriers to what they're trying to do. And that's all we're hearing. Shika Dunyo, who's on our patient advocacy team here, can tell you, we're hearing constantly about all these barriers that some of you referenced. And when that happens, then our ability to innovate continues to be blocked, and then the system starts to be jeopardized. So I think being able to take this period of disruption and being able to find seeds for how we can turn into opportunity to address things is really the challenge, that we're facing at Travere, and one that we're trying to lean into with the things that we think we do best.
Yeah, some great answers. I don't like executive orders because I was in Congress, right, the legislative branch, and so whether it's this president or the previous three that I served under, counting the current president in his first term, I think Congress doesn't necessarily. Right now, you're not seeing a lot of pushback from the Congress, but I think I'm hopeful that you're going to see in a lot of areas, particularly research funding, like I mentioned in my opening remarks, Congress is going to hopefully step forward. But in the meantime, what specific kind of funding programs and cuts that you've seen on the possibly on the chopping block that you feel like might directly impact the rare disease community? If anybody has anything that's kind of specific or just general comment.
It's hard to pick, but I think I'd be remiss to not start by talking about
5
Medicaid.
to 10 of them. No, I'm
yeah, got it. All right. I think I'd be remiss to not start with Medicaid, knowing that is a conversation looming large on the Hill in this moment, as members of Congress are really looking to their constituents and to advocates to hear about the importance of the program to their communities. Now is really the time to be talking about it. We're seeing that, folks mobilizing and engaging and informing on the value of that program to their lives, to their care, to their families, is really moving the needle in terms of helping them understand, again, what is worth protecting, what is worth preserving, and what changes mean in the actual sort of tangible way to families in the sort of individual lived experience in rare disease. So I think that is one of the top ones. I think also, obviously, we are watching very closely the ways in which changes to staffing, changes to funding are playing out at both NIH and FDA. Those are sort of critical pieces we know where a lot of work has been put in to advance rare disease development for patients and to really advance expertise, particularly at FDA, for staff to ensure that they are helping companies and helping communities navigate that process of drug development as efficiently and effectively as possible. So those are things we're certainly watching very closely and engaging on.
And I would just, from a drug, people who want to see that therapy comes to market, we're really concerned about incentives for addressing orphan and rare diseases. They were cut in 2017. We're worried they're going to be cut even further, and with 95% of rare diseases not having a treatment, we certainly think there should be more incentives, not less. And also to what Tori just said, this morning I was with Reedy McCarthy, who's the CEO of Stealth Biotherapeutics. They have been working with the FDA for about 2 years on a treatment for Barth syndrome. It has about 150 patients here in the U.S. They had originally were supposed to hear from the FDA in January, and then they just heard, actually just yesterday, that the FDA has put that application on hold. They had an advisory committee which was fully supportive of it. They've been working on that long. So, I would say from our perspective, we're worried about, in this period of disruption, brain drain at the FDA, and then, the concomitant NIH research that's, as well.
I mean, I'll just add, and I can't believe neither of them said it because we're all working on this together, but the list is so long, it's hard to remember everything. HRSA. So HRSA is one of the agencies that helps oversee our newborn screening ecosystem. So there have been substantial cuts to the way our newborn screening ecosystem is led and overseen. In the proposed FY 2026 budget from the president that we've seen, there are even further cuts being proposed to HHS, including collapsing the 27 institutes of NIH into potentially 8. And that would include also pulling NCATS outside of NIH and collapsing NCATS, BARDA, and ARPA-H together. So we're not sure exactly how that would work. So there are a number of things that, again, haven't happened yet, but are on the potential near horizon that we as a community need to be collectively activating on and messaging around our concerns around that to Congress. And then just to build on what Tori talked about related to Medicaid, we've been working with our patient community to make sure that Congress is hearing from us, because this is a conversation that's happening right now in Washington while we're sitting here, as members are trying to figure out how they're going to really solve for the budget cuts that they have to make and what is going to get cut and trimmed. And they need to hear from constituents if there are things that are going to be very unpopular, if those things get cut and trimmed. And as we're talking to members of the rare disease community, there are almost some false understandings of what provides security. And so some of the folks that we've spoken to have said, well, I'm going to be okay because my Medicaid eligibility comes through a waiver program, or my Medicaid eligibility comes through the Katie Beckett waiver. And our messaging is actually, you're some of the most vulnerable families, and you really need to get in and talk to your members and talk about what your Medicaid enables you to be able to do. If having Medicaid is what enables you to be at work, or enables somebody in your family to be at work, or enables you to remain in your home and not be living in an institution, talk about that, share what that looks like. And so those are the types of things that we have to be able to make sure that Congress understands what the distinct face of the rare disease community is when it comes to some of these programs. That's really important. The other thing is CDC has been impacted pretty significantly by some of these cuts. And there's some really important surveillance data and important resources that come through the CDC to our patient communities related to newborn screening, related to provider care and quality standards. And so those are programs that we're really concerned about. Now, the question of whether some of these are going to go into some of the new infrastructure being proposed, we're not yet sure about. So again, these are places for, along with disruption comes opportunity. And so it's also a really dynamic environment. So it's an environment where this is where the strength of the advocacy of our community comes into play, because we should be advocating for the programs that matter to us to remain within prominent positions within some of these newly formed agencies and infrastructure.
And just to reiterate the point, I do think that there's so much value in sharing our personal stories and really humanizing some of the issues in the programs and the agencies that we are fighting for. And further, I feel like for us, at least, we've been working a lot with our local state legislature, and I think that has been somehow, it feels more empowering to me because I know them and they hear me, and it seems that they are on board with what our concerns are. So I guess one of the things, I am always, as a caregiver and as somebody who works with our foundation to support other patients and families, that access is such a huge problem at times. And it is so frustrating. One of the things that I'd really like to work with our state legislator on, the insurance regulators are trying to eliminate barriers like step therapy, which I just come across this time and time again, and it just does not make any sense to me. And I really would love to shift the focus from the insurance to the rare disease doctor who's an expert in that space, who knows the patient, to make that decision. And it just seems like such an obvious, logical thing to have happened, but it's not really.
Yeah.
So that's something that I'm really focused on.
Good. Well, I worked both on step therapy and prior authorization issues when I was in the Congress to open up access and some of the ridiculous things that happen with step therapy when you change providers. And I'm with you on that. I think there's a lot of people in Congress that are on your side on that one. But you're talking about state level advocacy kind of segues into my next question that I wanted to discuss with you all. Is, okay, we're here in Washington, D.C., but what can we do at the local and state level to be effective in this particular space? And it's really, I think, really an important piece, right?
Yeah, I hate to be the one always starting, but really appreciate the opportunity. State work is just as important as federal work. These fights are not isolated from one another. A lot of the issues we can see at the federal level trickle into issues at the state level and vice versa. So it's really important to be engaged in both. And state level gives advocates a really great opportunity to be engaged even more with their decision makers than maybe they have access to at the federal level, where, there are literal distance sort of barriers in place to those activities. So one of the things that NORD does is we have worked very closely with advocates in many states across the country to establish rare disease advisory councils that really help give that venue for advocates to engage closely with their legislators at the state level, help them understand the rare disease patient journey and needs and experience, and sort of the day-to-day experiences as well, so that they can make decisions on legislation with rare disease patients in mind, from everything from coverage issues through to newborn screening to other kind of issues as well. So absolutely a great way to get engaged. NORD has worked with advocates. I think we've set up 30 so far across the country. So there's certainly more to be done, but there are great ways and venues to get involved. And this is just one venue through which advocates can involve.
Sure. I want to comment on that because from a member of Congress's perspective, advocacy, as you all know, is a sustained long-term effort over time and consistent and sustained. If you get to know some of your state legislators, one of these days your state legislator may be a senator in the U.S. Senate or a House member. The person that replaced me was a state senator, and there's a state senator next door. Almost everybody in the Indiana delegation started at some point in the state legislature. So if you're a long-term advocate for rare disease, if you've gotten to know them, 5 years, 10 years before, as they transition to the federal level, that relationship really does matter. So I just wanted to say that from a former member's perspective, that advocacy does matter, and it can be a big advantage if you get to know them before they come to the federal government. But let's continue on with state and local advocacy.
I also love that you called out local, because I have a couple examples from that. So first of all, I just have to say I really appreciate the RDAC work that NORD has done. There are also state orgs in the states. So in addition to all the RDACs, and many of you are probably working with or affiliated with state organizations, and those are phenomenal groups to be partnered with. So many states have both, and some states have one or the other. And those are powerhouses in the states where they exist. I love the highlighting the power of state representation. And, our rare disease community is fierce, and we have so many community members who live next door to a state representative, or, are at the playground with a state representative, become really great friends with them. And next thing you know, there's a concept that's becoming a bill and is working its way through, and then can sort of catch fire throughout the U.S. We had a condition, Duchenne, added to the Indiana newborn screening panel just last week, because we had a family that just introduced that concept to the Indiana newborn screening board, got herself appointed to the RDAC, and next thing you know, that one's moving forward. And some of that evidence is key when we think about moving things forward to federal panels. This is a room full of fierce advocates. You know how that works. So it really takes a crowd to draw a crowd. State legislation can help do that, especially in an environment like this, where some things are going to take a little bit longer to move federally. They can move on the state level. The other thing, though, is just to call out local policy. I think this is a really important environment, especially when we think from the context of some of our conversations earlier this morning. What are the barriers to participation in clinics, in clinical trials, what are the barriers to access, and understanding from those sort of microcosms of our communities? Are there local policy solutions that we can be working on now? Well, everybody's distracted over here. Are there things that we can be doing to solve locally? I had the privilege of meeting with some providers in New York City just a couple of weeks ago. And there were a couple of providers from the Bronx who were talking about access barriers for gene therapies. And they, while everybody else was talking about, are you offering gene therapy to all of your patients? What are all sort of the typical conversations that they have? Those providers literally stopped the panel and said, literally, I sat back. I'd never heard a panel like this before in my life. And they said, first of all, you need to understand that there are so many dialects spoken in our clinic that we don't have translators for all of them, that many of the people in our clinic are Hasidic Jew and different. And so we spend so much time even finding translators and translation devices so that we can do really meaningful care. And they talked about the time they take to do that. And then they talked about that many of the parents haven't, because of how they've come into this country, don't even have second grade educations. So the time it takes to even explain what a cell is and what a gene is before they could even talk about gene therapy and clinical trials. So to even start from that level, and they talked about what kinds of education and a brain pop video or something that would save them so much time, that if there were things available to the parents, that would be such a time saver for the providers. It was such an aha. But then they talked about in New York City, there is a policy that one parent has to be, it's a one-on-one for a parent and somebody in a wheelchair on buses in New York City. So if there were a parent that had two children who used wheelchairs, they can't bring both children to their clinic together. So that's a barrier to get to see them. And so they just sort of went through the barriers to even get to their facility. That, to me, is on a local policy level. You could work on that policy with the mass transit system, and you would right away start to eliminate some barriers to clinical access and even clinical trials. So to me, like, we, at this moment, while there's so much happening on the macro level, we could as a community be really breaking down some of the barriers on the micro level for families that would be life-altering for those families that have to get to their clinical care providers. How many, if New York City does that, how many other cities have policies like that in the busing and metro systems?
Sure. Any other thoughts?
No. I just want to pick up on one thing that was said there about kind of the community-based level, because if you're in rare disease drug development and you spend $1 billion in 10 years to get a drug to market, and then, God willing, everything goes right, and you do, you really want to make sure that nobody's left behind. And, at Travere, what we try to do is to radically listen, try to get feedback on how we can do that. So if you or your loved ones are impacted, whether it's working through, a NORD or an Every Life or a local state organization, just reach out and let us know how we can do that. We get our strength working with partners. So, in Atlanta and Chicago and Philly, we're working with NFCure Kidney International. With AKF, we're working on the Kidney Health for All initiative. But these are all initiatives that provide community-based support for people living with rare disease. We now, in our patient hub, because one of the diseases that we're in, IgA nephropathy, disproportionately affects Asian Americans, we hired a Mandarin speaker. We never thought, should we do that? But that, people brought that to our attention. So engage as much as you can with all the stakeholders and tell us how to help.
Sure. Makes total sense. I guess as a physician, this kind of question kind of came to me a little bit ago, because something that one of y'all mentioned about the emergency room physicians and that. So what can we do better to educate providers, physicians starting in medical school and maybe through residency, to bring more awareness to the challenges seen in the rare disease community? And I can tell you from a training perspective, if you go to the emergency room at a big city medical center, you might initially see the intern or the second or third year resident, and that's fine. Everybody has, but then I can tell you from experience that could be your barrier right there, because they're trying to get through their day, and something that's very complicated and not clear, like a person that has symptoms of a rare disease or complications of it. So what are your thoughts? What are people's thoughts on how we do better, not only educating the public, but how do we educate providers in a better way to take down some of the entry barriers and get recognition for people with rare disease?
Yeah, that's a great question. I've been thinking about that, actually. I think, of course, you could do it at, you could start with one hospital and try and do in-services and educate that way and have, lunchtime conferences. But I think one way that could do it very effectively is if you can partner with their national meeting. So I know radiology has our national meeting every year in November in Chicago, and we find that for emergency medicine, we find that for gastroenterology, and you go and see if you can partner with somebody who will allow you to do a presentation. I feel like that way you get the greatest number of people in training, in practice, and at their national meeting, and the greatest number for that specialty could be the biggest impact. Now, I think also all right, well, let me stop there. I'll follow up with that later.
Well, I'll actually turn it over to Tori and to Annie, but I'd say as somebody who's living with a rare disease who ended up in the emergency room a number of times, empowering caregivers to be your best advocate. Because I know when I was in an emergency room, which was far too much, my wife always knew what the hell was going on, and rarely did the intern that showed up. So I think part of that is it's not only the provider education, but also the caregiver, empowering the caregiver in training so that they can really advocate for the patient, and particularly when there's things like a language barrier or anything else.
Yeah, I would agree with that in healthcare in general, right? You have to advocate for your own health, and family members have to advocate for you. It's a very important piece of healthcare. Well-intended people, still don't always recognize or do the things that they need to do, not because they're trying to not provide care, but it's because they don't understand the circumstances. And so personal advocacy or family advocacy, I would agree with you, especially in this space, is critical.
Yeah, I'd just like to add another aspect is the clinician peers, right, who are fierce advocates for rare disease patients and communities. NORD has a rare disease centers of excellence program. We have over 40 participating different centers across the country, a lot of which are hosted in academic medical centers. But those are really folks who are so engaged in the rare disease community challenges and want to champion, making sure that patients with rare diseases have access to clinicians who can understand their journey and help them find their way, who can help them get diagnosis. And so I think that those folks who are really fierce advocates in those centers play a really important role as well in helping to educate their peers and helping spread awareness about different rare diseases and rare disease needs across the community as well.
So we've done a number of studies that have really helped us move from these back of the envelope estimates around the lived journey to having some real data around it. And one of them was looking at what the diagnostic odyssey in rare disease was and did some patient journey mapping around that odyssey. And we're really grateful to the communities that worked with us on that. And we found that the mean diagnostic odyssey in conditions that had ICD codes and that had a care standard was more than 6 years. It included an average of 4 out-of-state trips for peds and 5 for adults, and that assumes that you have reimbursement to go out of state. And included 17 providers. And so I think we really need to think about what's happening on that journey. And we also have details about how many of those were ED visits, how many of those were primary care visits. There was one dad who we spoke to who described his son along that diagnostic odyssey as having what he called specialist syndrome. So his son would essentially be diagnosed with go down a rabbit hole of whatever the specialist, the attending he saw in the emergency room was. And then he'd be put on all these meds and sent down this sort of rabbit hole of referrals based on whether the specialist was into metabolics or into pulmonary health and so all of a sudden he'd now have side effects related to these diagnoses. But in this day and age, there's really no reason why some of this can't be more automated. Why you couldn't just have linked to the ER some very centralized information about rare diseases that would help serve as a guide to medical providers so that if a patient came in and there were certain signs and symptoms that were linked to what at NCATS they refer to as zebra triggers, because we now have enough information around if you are going to the ED a certain number of times, or if a patient is complaining of a certain number of, if there are things that are coming off of the developmental path, that should be a trigger to providers that there is something going on, and that there could be questions that providers are asking that would raise some flags. Not because this is a patient that is drug seeking or is worrisome, but there is something going on that this provider should look closer at. And that there are clinicians that could very easily create a roadmap to aid any physician, that you wouldn't have to be a specialist in rare disease, but might get that patient to some better care more quickly and actually save resources, but more importantly, save the heartache of that patient. And I think as a community, we could probably pretty quickly come together and create something that would just pop up on every EHR and every ED and just create a much smoother roadmap to a better patient journey for an encounter for a patient.
Yeah, I would think with AI coming in, I know AI is a buzz term, right? But in healthcare, it's real. And I think you're right. I mean, this space seems really ripe for the development of the data that then AI platforms can access and utilize that might, in that emergency room, whether even above and beyond what might be on an EMR prompt, right? Maybe even more. But as you all know, AI is only as good as the information that it can access, right? And so, yeah, having more and more really in-depth data in your space seems like an area of promise, to your point, I think. Yeah.
Yeah, and just to add to the conversation about the ER, there are already, well, actually, during the time of my training, there was a protocol that was created specifically to address stroke patients. And it is because they come in with, a very small window of time where you should intervene unless that person is going to be permanently disabled. So during that time, there was a coordination of different departments. So I'm telling this story just to tell you that it is possible. There are protocols in place, and we could maybe sort of piggyback onto one of them. This is the way the stroke protocol works. When a patient comes in and they're suspected of having stroke within a 6-hour window, they get fast tracked through the ER. They go straight to the scanner. And somebody on call, a neurologist, is waiting for that result. Those images are fast tracked to radiology. That goes to the top of my list. It's in red. If I don't interpret that image within 10 minutes, it starts flashing. I get called. I mean, this was an amazing thing that they did. And when it was in place at our hospital, it was great. After that, I noticed that it was implemented in multiple hospitals across the country. So I feel like once you create that model and it works, people will follow. And so I do think that there's a lot of value in investing in trying to figure out the protocol that works best and one that you can add other patient populations into.
Yeah, I mean, stroke care, coronary artery care, both of those are now pretty much protocol-driven. Patients bypass all the delays to get to therapy. What a great panel. We were kind of out of time, so thanks to everyone.